Rai and Dr. Ulok Rai. Over to the chairperson.
Thank you, sir. Professor Rajeev Agrawal is an excellent orator and an academician. It's always a pleasure to listen to him. Over to you, sir. Please go ahead, Dr. Rajeev.
Thank you. Thank you, Dr. Alok Rai, and my thanks to Dr. Manoria also for providing me this opportunity. And it is yet another a biomarker for understanding cardiovascular disease, like Dr. Nanda spoke about epicardial fat, which is, I still feel, is less exploited to its best potential. And why we are talking about this is because if everyone thinks alike, then really no one is thinking. And that is the essence of my talk, that we have to think very, very differently. Mummies talk a lot about atherosclerosis. In fact, the Egyptian mummies were studied on CT scan. It was found that these mummies, thousands of years before Christ, also had atherosclerosis the way we see it today. And it was seen in Inca mummies also 10,000 years ago. So atherosclerosis and calcification, they are not new phenomena. They are very old piece of knowledge. Only thing is it has to be exploited, practiced, and utilized in day-to-day clinical medicine. I'm sure everybody remembers the Time front page with having a shot in the ear, which made him President of America. My interest is to show his calcium score over a period of time, as it is mandatory for American presidents and astronauts to have calcium score. And remember this slide, there is a progressive increase in calcium score. And I'll come back to this slide before concluding my talk. The coronary artery calcium is a primary prevention tool. Usually it is not applied to low and high risk groups. That means don't try to do a calcium score in a patient who has got CABG or an angioplasty kind of thing. It's not a tool for secondary prevention. It is a primary prevention tool. Just a basic understanding that atheroma matures over a period of time, and there is some calcification starts coming up once it moves from fatty streak to evolving atheroma. There is a fibroatheroma with calcification, and that is where we start picking up. So you must learn the caveat that if you are doing a calcium score in a very young patient, it may be falsely negative. That is how inflammation starts, microcalcification starts, and then macrocalcification starts. Today, our tools are only able to pick up macrocalcification on CT scanners. We need further refinement of technique to understand microcalcification. Smooth muscles play a very important role. They are pluripotent cells. They can become adipocytic, like foam cells. They may become contractile. They may be aging and inflammation, and sometimes they become osteochondrotic as the atheroma evolves and calcification starts. So calcification in coronary artery is a local smooth muscle mediated phenomena, not a phenomena which often think that it is being caused by serum calcium. So the smooth muscle cell can behave in a very, very different way, and osteoblastic transformation of vascular smooth muscle cell is responsible for atheroma calcification. Coronary calcium is not aging, it is the ectopic bone formation and influenced by inflammatory, metabolic, and master transcription factors, which results in bone morphogenic protein. The technique, I am sure, is very, very simple, simpler than doing an ECG. Simpler than doing an echocardiography. You have to just put the patient for 3 to 4 minutes on a CT scanner. There are no drips. Only thing you need is a little bit of ECG gating, and then you get a reading of coronary artery calcium. As Dr. Nanda pointed out, the upcoming risk of frequent CT scans and cancer, the calcium scan exposure is really very, very low, far lower than mammography, angiography, and nuclear imaging. So it is practically very low exposure for radiation, and one should not be worried about exposing the patient for radiation. It is not CCTA, it is not coronary angiogram where the radiation is more. In calcium scan, you just need a 1 or 2 minutes of exposure to CT scan with minimal of radiation. The guidelines recommend at the moment 2AB recommendation for doing it in intermediate or selected borderline risk individual to do a coronary calcium scoring. Traditionally, the first time the recommendation came in 2018, where in intermediate risk group patient, coronary artery calcium scoring was advised to up risk or low risk the patient. So in intermediate risk group patient, if you do coronary artery calcium scoring, it will define the up risk or de-risk the patient. Our lipid association has also talked about the coronary calcium score. Once you are 100 plus, you definitely need aggressive lipid lowering, even in primary prevention. And if you are more than 300, your optional target may be as low as 30. So these are primary prevention patients where on the basis of calcium scoring, we are treating them to as low as 30. And that is the essence and beauty that in primary prevention, you are picking up patients who are prone for atherosclerotic events in times to come. Is a strong predictor of coronary events and predicts better than all risk factor combined, because risk factor talk of the probability of the disease. Coronary artery calcium speaks of the footprints of the disease. So it relates to translation of risk factors to disease. While risk factor is a probability, coronary artery calcium is a footprint of a disease. If you have more than 3 risk factors, then the risk of developing coronary artery calcium positivity over a period of time, it becomes 2 times. So it is a risk factor translation into disease. The risk is 10 times of events. If coronary calcium score is 100, it is 1000, then it is 60 times. So there is an exponential linear relationship between coronary artery calcium score and the future risk. Now we are thinking of doing coronary calcium score in even younger patients, those patients like FH patients, where you want to see whether their high LDL is translating into disease or not. If it is translating into disease, people with cluster family history, then you have to be very, very aggressive at 10 years, 15 years, 20 years. You don't wait for 40 years to develop them atheroma. At the moment, the recommendation is the age cutoff, as I told you, it takes time for calcification, is 45 for men and 55 for women. And that is probably the handicap of the technology, as Dr. Nandar spoke about the echocardiography and visceral fat, epicardial fat. Similarly, we need to have better scanners to pick up those very, very little microcalcification. A zero calcium score is priceless because it gives you protection, almost protection for 3 to 5 years, depending upon patient risk. And if you see, calcium score 0 is the most important negative risk factors for events. If you have calcium score 0, then 90% people will not have plaque, 7% people will have some kind of plaque, and 1.8% will have obstructive disease. So it's a very, very simple test which predicts lot of future events. And there is a similar study from Miami Heart Study. If calcium score is 0, Any plaque 13% if the LDL is less than 70, 28% if LDL is more than 190, and if calcium score is 0, and at all levels of LDL, you are bound to have 100% patient will have a plaque. So calcium score of 100 gives you such a solid information that this patient has got now some kind of plaque, and we start putting these patients almost in secondary prevention category. And similarly, if the calcium score is more than 100 and you combine with LDL, and LDL is more than even less than 70 and more than 190, then 66% will have a kind of obstructive plaque, while the obstructive plaque will be absent in this population. Another way to look at it, this is calcium score 0 and calcium score more than 0. The moment the score is more than 0, LDL becomes important player. If the LDL calcium score is 0, LDL doesn't play much role because this patient is not expressing disease. The number of event is 0.07, but it increased to 20-fold if you're just more than 0. So more than 300 is a very, very significant phenomenon. Not only you have to see calcium score, the distribution of calcium score, that it is in left main or it is distributed all along the arteries. When you repeat this scan, this is a patient who has a calcium score 0. When you repeat this scan at 5 years, 28% will have more than 0, and the event rate will be 5.7, and 72% patient will continue to be 0, and event rate will be 1.8%, almost 4 times the event. So it is very, very important to see what is the calcium score, and if your calcium score is 0, you are supposed to repeat it after 5 years, and if it is negative, then we call it double 0, and then you have almost 10 years of warranty. Diabetic patient, they do worse than non-diabetic patient. This is a corona time CT imaging that also showed non-gated calcium score having the same correlation as the gated calcium score. Number of disease vessels, they are more important. Revascularization helps than the severity of ischemia. And the same thing has been found with calcium density and calcium area. Calcium density doesn't speak so much of the disease because they are stable plaques, but if it is distributed on a larger area, it means there is a positive correlation as shown in ischemia trial. Number of vessel involvement is more important than the severity of ischemia. Similarly, the distribution of CAC is more important than otherwise. If you combine coronary artery calcium with lipoprotein A, the upper quintiles, they will have far more effect on coronary events than otherwise. This is the highest quintile of calcium score and LPA, and you see the worst possible outcome, 4.5 to 4.5 times. When a calcium score equates to secondary prevention, any score, if you look, is more than 300, then the ASCVD risk and the patient with calcium score, they become same. So you have become the same as that a patient who has got a disease. So calcium score more than 300 almost make you like a patient individual who has had an acute coronary event, and it will be treated very aggressively. If the score is more than 1000, then the population is very, very high risk, like a 4-year population, and you have to be very, very aggressive in risk factor management. In chest pain clinic, if your calcium score is 0, 56% patient will have a calcium score 0, then you can really discharge them. Prop T negative, calcium score 0, almost no possibility of a disease. This is how you can look at it. Less than 1 in 100 patients with calcium score 0 will have obstructive coronary artery disease. It costs lower and lower radiation. The calcium score can be exploited in primary prevention, and this is being used in aspirin And the simple diagram you can carry home is if calcium score is more than 100 in primary prevention, where there is no aspirin recommendation, there is a justification to start aspirin in this patient population. So that is one advantage of calcium score, that more than 100 you can start aspirin in primary prevention. And that is how aspirin has got a role to play in primary prevention. Impact of statins on cardiovascular outcomes. If calcium score is low, 0, statin has got no role to play. That means you will de-risk these patients. If the calcium score is more than 400, you can see the best effect of statin, just making us to understand that more the disease, more is the statin effect. And using statin in 0 calcium score is practically of no advantage. Antihypertensive therapy also, even if pressure is less than 140, ASCVD risk is less than 15, very low risk population. But if the calcium score is more than 100, and this is a sprint-like eligible 120/80 pressure, the number needed to treat will be just 14. So making us understand that calcium score can even guide the low-risk patient population of hypertension to treat or not to treat aggressively. Then in COMPASS patient, once again, calcium score calcium score between 100 to 300, the patient will be benefited a lot by these patients because calcium score predicts a higher risk. If you are non-dippers, you are likely to have more calcium score. And role of primary prevention cardiovascular disease, just to summarize that, it identifies higher risk patient. So aggression to treat risk factors in primary prevention becomes very, very high. This is about familial hypercholesteremia. Young patients, if your calcium score is high, then these patients will have poorer outcomes. So there is an 18-year-old boy, 10-year-old boy who has got FH and no expression of disease. That is one caveat where you will do a coronary calcium scoring. If the calcium score is 0, you know that this patient is having a good natural history. If the calcium score is high, even in FH patient, then you will say that this patient is likely to have a malignant course of disease. When you do lipid lowering, one caveat is when we use statin, it causes calcification of the arteries. It entombs atheroma like tuberculosis. Body heals by fibrosis and calcification. So if you are using statins in primary prevention, because of calcium score or otherwise, you are not supposed to repeat a calcium scan because they are likely to be high. Now we are having studies, AI-based studies, where we can identify whether this increase in calcium score is because of expression of the disease or because of statin calcification, but we don't have those algorithms in the country now. Somehow PCSK9 do not cause that much of calcification. So calcification following lipid lowering therapy is specific to statins. How we look at it is like a mammogram of the heart. And this is Dr. Nathan Wong presented a data, and this is a JACC review article, very important. And they have taken bit by bit of calcium scoring, and they say that calcium score stage 4 more than 1000, LDL is 55, while we advise something like 30 in this patient by Lipid Association of India, because we feel this is the best time to work on these patients when they have not expressed disease. So anybody who wants to learn and practice calcium score in primary prevention, then this table is very, very important. Then the same can be applied in diabetic. A diabetic who is 10 years, no apparent vascular involvement. Calcium score can identify these patients that who will need earlier GLP-1 receptor analog or SGLT2 inhibitor. If you know, if you have diabetes without risk factor, without vascular involvement, GLP-1 and SGLT don't have any benefit, because it is too early a disease and the vascular events are very, very low. But if you do calcium scoring, then one can make out that even low dose aspirin can be started if your calcium score is more than 100. This is semaglutide. If calcium score is more than 300, NNT for MACE is 79. If calcium score is 0, NNT is 653. So it is important that if you bring in calcium score when you are confused, it is not tiebreaker, it is an arbitrator which will define who are the patients who will be benefited with high-end vasculoprotective therapies. This is just a few days back, 2 patients, normal perfusion, no coronary artery calcium, coronary artery calcium. So here is a patient who has got no calcium, normal perfusion, you do extremely good. But if you have calcium score positive, even with normal perfusion, even with normal ECG, the event rate will be something like 7%, justifying that you are having a beginning of the disease. Normal ECG, calcium score positive, normal perfusion scan, do not leave these patients and do a risk factor management. Major guidelines talk about calcium, and there are several ways. The specialty guidelines, SCCT and NLA advise use of aspirin if the calcium score is more than 100. The US preventive guidelines do not take into account this, and they do not advise aspirin. Coming back to the last part, another a minute or so, our president had got a rising calcium score, and this is his report, which is published in April. It is on net, you can Google it. He is 78 years, resting heart rate is 62, blood pressure is 128/74, no vascular event recorded so far. His total cholesterol is 140 and his is 51. Total cholesterol 140, LDL is 51. He is 78 years old with high calcium scores. And you know what he is getting? He is getting rosuvastatin ezetimibe combination along with aspirin. So ladies and gentlemen, just to advise you that even at 75, the guidelines stop. They do not recommend statin in primary prevention after 75 years. But here is a case that President of America is getting rosuvastatin, ezetimibe, aspirin. As I told you, if you cross 100, you come on aspirin. So the president is getting rosuvastatin, ezetimibe, and he's maintaining a LDL as per their guidelines to 50 in primary prevention at 78 years of age. That is the value of coronary artery calcium. Emphasizing again one point that we do a combination lipidology today. We do not practice high dose statin, and that is what president had been given. So many lessons. Primary prevention, 78 years, achieved LDL 50 without vascular accident because of high calcium scores. He is on aspirin, he is on combination therapy. So I'll just end up showing that coronary artery calcium score is not a risk factor. It's the footprint of a disease, and it provokes you to take aggressive steps. If it is more than 100, more than 300 is the next station. And if you are more than 1,000, then you are a Fourier kind of population. So I'll end up by saying knowledge is what we learn. The bigger part of knowledge today is what we unlearn and relearn and apply to our practice. And this is a simple test in my area. My all CT scanners in Meerut has got coronary artery calcium score. They do it for 2,000 rupees. And we do it very
We
well.
are free, okay, busy. Good morning.
And I'll just end up saying
Free, okay, busy.
old breaks.
Hello, free, okay, busy. Oh.
Dr. Rajeev, you have become mute. Dr. Rajeev, you have become mute.
Ladies and gentlemen, we have to carry new bricks to make a new house for primary. Thank you very much.
Thank you so much, sir, for the very lucid and talk, and you have given very clear carry-home messages that coronary calcium score is not only a risk
महाराज जाना
factor and
सुन
risk
रहे हैं।
enhancer, it also helps in taking therapeutic decisions for both primary and secondary prevention of coronary artery disease with a very low radiation exposure.
Yes.
If there are any questions.
Thank you,
Yes,
Dr.
sir.
Agarwal.
Sir, can I
was
ask a
an
question?
excellent presentation. I have a question to ask you from the chair. How do you, is a zero calcium score, it doesn't rule out a non-calcified plate. So how should clinicians interpret a zero calcium score in context of other risk factors?
You see, in medicine, there is nothing like mathematics and 100%. So calcium score almost practically rules out. I won't say rules out. There is a 7% possibility of calcium score 0 having a atheroma, roughly about 1.8% probability of having obstructive atheroma. So these are painless, drop T negative patients. So I'll say the probability of the disease is normal. If you do a normal angiogram, it doesn't mean there is no atheroma until unless you do a CT angiography. So what is your perception of normal angiogram on luminogram is also based on your ignorance, not on fact, because these patients may continue to have atheroma. So I'll say there is no investigation which is absolute except
बोलो
CTA.
डॉक्टर राजीव
Otherwise, it's a very good tool. It's a very good tool to use in majority of the patient. Like chest
I
pain,
have Dr.
like
Rajeev can
yes.
Dr. Rajeev, can I say something? You know, I cannot agree too less with you. I had a patient on a very routine examination, diabetic patient, 72 years old. His calcium score was 450. He was from Bangalore, so he was worried. So I said, you go to your local family doctor. And then through his family doctor, he showed to the local cardiologist. He said, nothing is okay. Then he said, no, Dr. Debris from Mumbai has said, so let me show to somebody else, senior person. And then eventually within 5 days of this story, his bypass surgery was done in Bangalore. So this calcium score is extremely important, as you are saying, sir. And this 450 that I was able to elicit gave us, great insight into his heart, and we were able to save him. Thank you, sir.
It
I
is
have one
like
question
Dr.
to ask
Nanda,
Dr.
just a
Rajeev.
minute.
I have one
It's like,
question to ask. Yeah.
yes,
Now,
yes.
quite often there is a dilemma in relation to clinician's decision and patient's choice, whether it is angioplasty with multiple stents or a CABG. So, in such a situation, can the calcium score give
No.
some added benefit of
No, sir.
prognosticating?
No, sir. Calcium score is a screening tool in primary prevention. If you
Okay.
want to decide this, it is CTCA which may decide that the arteries are very calcified, not calcified, there are focal disease. So CTCA will be another choice, but kind of calcium modification techniques now, it depends upon the skill of the angioplaster, that many patients so-called bypass surgery are being subjected to CABG, to angioplasty and vice versa. So calcium score is not a decision maker in that situation. Bypass
Thank you.
versus angioplasty. No, it is
Sir,
not.
one question. Risk of radiation hazards in patient scanners.
I told you it is almost less than 1 SMV, less than 1 SMV, which is even less than a mammogram. It is many times less than a coronary angiogram. So this is not CCTA. Don't confuse it with coronary CT coronary angiography. It is not CT coronary angiography. It is just lying in the machine doing a coronary calcium score. It's a very good screening tool. Maybe if you are powerful, instruct your CT scanners when you ask HRCT for different region, ask them to charge another 500 and 1,000 rupees and do a calcium score as a bonus as a community service.
Dr.
So we
Rajeev,
are-
as you said,
Yes.
after statins, calcium
Right there.
score is not reliable. After using statins, calcium score is not reliable.
Yes,
So
sir.
is there any method by which you can decide how much calcium score is due to de novo disease and how much calcium score is due to statin therapy?
That's a very interesting question, and people are working on this question. You see, the calcification following statin therapy specifically is related to atheroma. So if you repeat a scan, the earlier disease will become denser. If it is a spread of the disease, it will be a linear distribution of the disease. Now there are methods coming up, AI based, that will give you an idea whether it is a statin related or expression of the disease. So this is a very good thought, a very good challenge, because repeat scan is not possible. So industry is trying to solve the problem, not yet solved. It is a genuine problem.
The
I
other
like
issue is
to, can I make a
previously.
comment here, sir? If you
Yes.
allow, can I make
Yes,
that?
yes, please.
So, Dr. Rajeev, we are a part of one study whereby we are giving inclisiran to patients and looking at their coronary ticks. And interestingly, we are repeating the scans. So as you see with statins, you see a similar effect coming with inclisiran therapy when you lower the cholesterol levels. So the plaques which are already there, 50 to 60% stenosis, they become more dense. So
Yes.
what is really happening is it may not be just statin, it's just the cholesterol lowering. When the cholesterol is being replaced by the calcium, making them more stabilized. But for screening, it may not give you a decent idea if the patient is there, but it will definitely tell you that there is a disease. Still, it will be, a valuable asset. Because this will only show, even if the patient has calcium score, whatever, and he is on statin, it will still show that there are plaques.
You see, calcium score, one thing one has to carry home is a calcium score does not mean, and it is not synonymous
Yeah.
with obstructive coronary artery disease.
True.
One has to understand this. Regarding your inclisiran point, I'll say that it has not yet come in literature. It may be coming up once you publish that kind of. Right now, the literature suggests that inclisiran causes less calcification than statin. That is what I can say. It causes less calcification than the statin. Statin is more notorious, and I told you maybe your prediction comes true that it is a healing pattern. Body heals by fibrosis and calcification. So irrespective of the agent used, once you heal atheroma by N2,
Dr. Rajeev, previously zero calcium was supposed to give a 10-year warranty, but in slide it is reduced to 5.
Yes, it is 5
Any
years.
specific reason for this, or is it because diabetics?
Because when we understand more, we see disease more, we find that it is not possible to predict. 10 years, the events start coming. I showed you 28% people will have atheroma, or more than 28% year on 5-year follow-up will develop calcium score more than 0. So when we study these patients more and more, we realize that it is not a foolproof thing, and roughly 1/3 of the patient after 5 years will have calcium score more than 0. So there is a concept of double zero. If you have double zero, then you have 10-year warranty.
How reliable it is in diabetics and smokers?
This is another good question. Diabetics, strong family history. Smoker, there is a caveat that it may be false negative. So this is a kind of
next session.